So this is just catching up after the talk this morning, and they're just going to answer a few of the questions that have been coming through on Twitter.
So one of the questions we had afterwards was about the vision, and Maureen Bisognano presented us with a very aspirational vision this morning about making huge strides in healthcare, and we seem to be saying that we should just aim for care that was good enough. So I guess I would say there's nothing wrong in the aspiration. We're not trying to say that. We should aim as high as we can. But as a patient, as a family member, what's important to me is that the care does not have to be perfect. It has to be good enough and without bad things happening. And overall, I want to get much more benefit than I can find. And our argument is more that if we aim for perfection, which cannot be achieved, and we know that many things are not done, and often the rules are not kept to and the standards are not adhered to. If we always say we have a fantasy of aiming for everything to be perfect, we are actually at more risk of harm, because we put stress on the system, we do not pay enough attention to detecting harm and responding to it, and many other strategies. So that's basically the argument.
Nothing to add.
Okay, so how do you control risk and non-compliance? I think this is more for René.
Risk of non-compliance is probably a matter of culture in terms of if you have no-go, clear no-go in mind, if you have limitation and controllability of the non-compliance, then you have a sort of control. So it's just a matter of considering how you control the non-compliance, not just having non-compliance. And there are many easy ways. First being to define where are the minimum bars in the acceptability of non-compliance, and how you can also compensate this non-compliance by strategies that make the patient in safe conditions.
Okay, so the third one was related to that, which was about no-go areas. And this, I think, arose from a comment by one of us about aviation, that if you go to the airport after the meeting and there is fog or big problems, they just won't fly. So safety is achieved by just not accepting the risk at all. This is something that René has taught me over the years. But in healthcare, we always continue. Now, sometimes it's necessary because it's an emergency, so you have to go ahead. But often there are operations which are happening, which are planned, and yet the equipment may not be there, and there may be problems in intensive care. Conditions are not perfect. If you like, there is fog. It's the equivalent. But there are no understandings, there are no agreed understandings about when you will not go ahead. So I think this is something to explore, about whether this is a concept that we should import from other industries about what is a no-fly, say in anesthesia.
If I may add something, is that for some cases we have defined no-go, but we are not respecting the no-go we have defined. So even when we have made the effort to define no-goes, we are not really in line with the aviation system. Once we are below the no-go, we never stop.
So do you want to do the safety 2 question? How does it relate to safety 2? And then we'll finish on home care. Would you be happy to do that? How does this relate to safety 2?
Safety 2.
Very cold like
well, that's a connection if we relate the system to resilience, of course. Eric's book is on resilience, so yes, we are concerned with resilience, but as Charles mentioned this morning, the healthcare system maybe has too much resilience, not enough, but too much, in the sense that this is a system which is little based on the compliance to procedure, and much more on the expertise of people. And the expertise of people means that they can recover unbelievable situation, which is really non-compliant strategies, betting on experts related to resilience. And in many cases, probably we do excessive resilience in the system, and we should probably make a balance between domains where we need this approach of resilience and domain where we should be in control and limit the resilience.
And this relates very nicely to the last question, which I think was about home care, about strategies for home care. And we do not either of us pretend to be experts on home care, apart from having experience of it in our own lives of looking after people. But the argument is really that the strategies you take for safety vary in different settings in healthcare, whether it's the operating theatre or the laboratory or in different settings. And similarly, home care is going to present a particular challenge. We've had a lot of trouble reducing medical error and having compliance with procedures in the hospital, which is a very organised setting. And in home care, it is the patient and their family who are in charge, and of course they may be very conscientious, but they are not trained, they're not skilled. So we have many new risks and new hazards. And again, this is not an argument against home care, it's a very important thing and absolutely applauded. But we think the management of safety in the home, the more techniques, the more injections, the more medications, the more equipment is in the home, the more it is like a hospital, then the bigger the challenge will come. And we haven't seen much sign of people discussing this issue. They've been solely concerned with the benefits of home care, and we think that is great, but we also need to consider patient safety in the home.
Okay. Thank you very much indeed.
Thank you.